the exam time, because some of you guys haven't done the exam yet. Some of you guys, I think they have done half of it, and so we have an easy lecture this morning. I'm not going to take a long time, but at least we just talk about a few little interesting things on our body. Where are we now? How many weeks have we done? Might be about 6 weeks from mid-August to end of September. So let's say roughly about 6 weeks. Let's say we have done 18 lectures to calculate easy, let's say we have done 20 lectures in total, starting from the first day of the class up till now. So let's say if our lectures are 2 hours a day, 3 times a week, 2 hours a day, and then if we have done 20 lectures, so we have spent about 40 hours of studying anatomy already, which means, I believe you must have done something significant for your knowledge. Because what I want to say this morning, it's just want to say, try to invest in yourself. So if you come to the class at least about 2 hours a day, 3 times a week, 6 hours, forget about anything you study at home or forget about the exam or the homework. If you come to the class regularly, you are studying anatomy about 6 hours minimum a week. That is quite a lot, because now your knowledge, I believe your knowledge is much better than when you started before this semester. And at the end of the semester, I believe your knowledge will be much better, and you will have a credit, 5 credits for completion of anatomy. So which means like you have spent 4 months for anatomy, and at the end your knowledge will improve and you will have 5 credits. This 5 credits on its own is not a lot, but it gives you a stepping stone to proceed to another step higher and higher up the ladder. So try to invest in yourself. When we say invest, how can you invest in yourself? Of course, you can invest time and money for yourself. Like, not to be too selfish, but hey, you need a little bit of room for yourself as well. Here, it's written here, I got it from Quora. If you don't invest in yourself, don't expect someone else to. So if you do not invest in yourself, nobody will be interested in you. So just try to invest yourself. So that's what I want to talk about. Hey, by the way, how much do you have to pay for the anatomy for the whole semester? How much did you have to pay?
I think it was like $30.
Oh yeah.
With the I have like the low income like reduced fees, but it was like $30, and then the book for like 30.
That's good, isn't it?
Yeah. For me, it's more. It's more than that. For me, it's like $46 something per unit, and then the books and your health and your registration fees.
Yeah. So like let's say $40. If you go to Starbucks, one cup of coffee is $5 already, isn't it? So yeah, instead of spending that money on Starbucks, just invest in yourself. Like after a year or two, for those who invest for themselves and who just stay away, there will be a big difference, because small little things count and adds up. Okay, let's move on. So let's look at this guy. Let's look at this guy, and it is like you and me, yeah. But when we talk about today is a little bit of nomenclature, right? Anatomy, as I always say, you know, it is learning Latin, learning Greek, might be a little bit of French, and just those little words which will create me for the first step. You have to swallow the words, terminologies. There is no way out, you know, no way out. You just try to relate. There might be some meaning, but you are learning Latin and Greek, and you have to swallow these words. And after a few days to weeks, then you become used to it, and then you can make some sense how to relate to each one. So here inside if we just shave this guy, and if we take the skin off, the bone in this area is temporal bone, isn't it? You remember that? And this bone here is frontal bone. Frontal bone, temporal bone, and here is occipital bone, yeah? And the side wall of the cranium is parietal bone. So that was in the exam, anatomy of the cranium. And frontal bone is only one bone. There is no right and left frontal bone. Of course, there is a midline suture, but that is insignificant, and don't worry about that. And temporal bone, we said, temporal bone is very thin part, which is called petrous temporal bone, and the solid part, squamous temporal bone. A squamous temporal bone and petrous temporal bone. So the thin part is squamous. Squamous means thin out and flat. So this area of the temporal bone is really, really thin out. So let's say if somebody fall and hit that area, temporal area, they can easily break the skull. And then there is an underlying blood vessel close to the squamous temporal bone. So the bone itself is thin and flimsy already. There is a big artery underneath. And if you just hit it, that artery is going to get damaged. And then, yes, it's going to bleed inside, intracranial bleeding. So that is the significance. This temporal bone, that is squamous region, and petrous. So as we say, you know, general petrosus. I'm not sure what it means, but petrous, general petrosus, it is really thick and hard. Thick and hard, guys, with the bone around the ear. So this is external ear, of course. External ear, we will have middle ear and internal ear. So the ear, the whole ear auditory system is divided into three. Outside, external ear, which is made of elastic cartilage, and you will have the tympanic membrane inside middle ear and inner ear. That piece of bone is really hard and thick, and you can't even crush it. That is what we call petrous, general petrosus, petrous temporal bone, squamous temporal bone, and this is occipital bone. Of course, in the occipital bone, if you feel yourself at the back of your head, you can feel the bony bump pointing like that. That is the protuberance, something pointing in the back of your head. Of course, you can feel it, so it must be outside. Occipital, of course, it is in the occipital region, and protuberance, of course, it is bump. So external occipital protuberance. So that is what you have here. You just feel it yourself. And this external occipital protuberance, and here we said temporal bone. This temporal bone, which is thin part, petrous temporal bone, and in the ear, so somewhere here inside, it is here, it is very hard bone. Of course, very thin layer, squamous temporal bone, we need to cover with the muscle. that muscle, because it is covering the temporal bone, we will call that temporal muscle, temporalis muscle. So now you can feel your occipital protuberance. You just clench your teeth and you put your hands above your ear. So these are your ear. So just put your hands above your ear, clench your teeth. So if you do that, you can feel the dense temporalis muscle. It is not a big muscle, but it is there. It is covering the squamous part of the temporal bone. And if you come forward, yes, this is your frontal bone. Hey, the root of the nose. As we know, the root has bony portion and cartilaginous portion. So yes, here, root of the nose, that's not a big thing for you. Bridge of the nose, forget about that. Hey, this is your cheekbone. You know the zygomatic arch, yeah? So this from here, petrous temporal bone come forward as the zygomatic process, and this is the zygomatic arch. You know your mandible, body of the mandible, and the mandible become angle here, come here and then go upwards. So that is what we call angle of the mandible. It's not a difficult terminology. Mandible, you know, everyone knows mandible. Body of the mandible, of course, the bigger portion is called body, and the angle of the mandible. Why this terminology important? Let's say if you are working for a emergency medical services, or if you are in a emergency room, that's the way you have to communicate. So if somebody being punched on the face and broken in the mandible, hey, I got this guy with broken mandible. Hey, the break is around the angle of the mandible, or it is in the body of the mandible. So that's the way, you know, you can communicate with another specialist, and it makes a lot of sense. So angle of the mandible, and this mandible become ramus, so it is just like going upwards, and it joins the temporal bone, temporomandibular joint. Here, temporomandibular joint. And as you remember, when we studied about joints, so joint is might be about number 3 or number 4 lecture. Joint, temporomandibular joint, it is a synovial joint. So temporomandibular joint is just anterior to the aperture of your external ear. So this is what we call tragus. And this is just right here. So the pain can be, so at some point, you know, everyone can get knee arthritis, isn't it? It's very common problem. Knee arthritis. The knee joint, it is a synovial joint. Temporomandibular joint, it is a synovial joint. So synovial type of joint, and we remember the basic requirements for synovial joint. It has got outer capsule, inner lining capsule, articular disc. So this is a synovial joint. Knee joint is a synovial joint. So if there is any pain or any incongruency, like when you chew it, when you open your mouth big and eat a big burger, and then you cannot close your mouth again because this temporomandibular joint can get like subluxate, you know, can want to come out. So there are a few people who have this temporomandibular joint problem. And if there is any irritation, inflammation in the temporomandibular joint, you got pain in your face. So the pain in your face or the pain in your mouth, it is nothing to do with the face, nothing to do with the mouth. It is coming from the temporomandibular joint. Eyebrow, supraciliary arch, a little bit different, isn't it? Okay, hey, I want you to feel yourself mastoid process. So this is your ear, external ear. So flip your ear forward and you feel somewhere bony prominence, hard bony prominence here, which is just behind the ear, just at the level of the opening of the external ear. So you put your finger in your ear and then go out, and at the same level, you will feel a bony prominence, bony pointing point. That is a process, Maastricht process. So Maastricht process is going to play an important role in later muscles, because this Maastricht process, you can see a big muscle here. Look at that. That is the big muscle, which is originating from the Maastricht process. Of course, this big muscle originates from the Maastricht process, and it goes, if you follow it, it goes, part of its fiber go to the clavicle, and part of its fiber go to the sternum. So what is the name of this muscle? Going from the sternum, coming from the sternum, coming from the clavicle, going to the Maastricht process. What is the best name, easiest name? A muscle coming from the sternum, a muscle coming from the clavicle is going to the Maastricht process. Hey, it's easy to say, sternocleidomastoid. So now this guy has got big, thick sternocleidomastoid muscle. Of course, it is going to the Maastricht process, which is just behind the ear. So look at that. This is what we call lobule. And this little bump here is called tragus. So temporomandibular joint is just anterior to the tragus. Helix, oh, so ear, human ear, you have to say this helix. External acoustic meatus, meatus means opening, outside external acoustic hearing, outside hearing opening. It's simple, isn't it? External, outside acoustic, mean hearing, meatus opening, external, and this is what we call lobule. This is where we put our earrings and that sort of stuff. Right. Let's strip that guy, the previous guy we saw. Let's take his skin off, shave his body, take the skin off, and this is what we are going to see. Look at that temporalis muscle. Now you can appreciate the temporal bone, temporalis muscle, temporal region, and any injury to the temporal region is important. Yeah. So temporalis muscle, it is not a very thick muscle, and as I say, you put your hands on your temporal region, clench your teeth, you can feel this muscle tense. That is temporal. So, and here, the muscle on your forehead is the same as the muscle in your occiput. Hey, that is amazing, isn't it? It's like, yeah, Amanda, Arturo, did you have any question?
Oh, Amanda had her hand first. So,
Amanda, you okay?
Oh yes, sorry, it was from earlier when you were talking about arthritis.
Yeah.
I was just gonna ask, like, is there a way that someone can avoid like having arthritis?
So I have to say, no, but we can improve it. So let's say in like many different things in life, you have to see as modifiable factor and non-modifiable factors. So non-modifiable factor is you can't do anything. That's like part of our life. And modifiable factor is it's something you can do. So I want to be a millionaire. Hey, my father was not a millionaire. So how can I become a millionaire? It's not easy. So I like from birth until like I go to school, I cannot change myself. But then if I work hard and do hard and things like do business and many different things, like many different guys, as you see on the internet, yes, you will become a millionaire. But one side is non-modifiable. I was born poor, and it is I have a high chance that I can still be poor or get just into the middle class. If somebody is like the royal family from England, yeah, Prince Harry, he's not going to be poor for sure. Even even if he spend loads, this who is his wife? No, I should stop there. So like whatever she does, whatever Harry does, he's not going to be poor. That's for sure, 100%. So like the same thing like arthritis. What is arthritis? The articular cartilage, which we hyaline cartilage, which covers the bone inside the joint, inside the synovial joint. That hyaline cartilage is gradually worn out. So that is arthritis. So with time, we keep walking, moving. That's part of our life, and this articular cartilage will worn out. So which means one way or another, we are going to wear out our articular cartilage because we are living longer and longer. So 70, 80, now we can easily live to about 85. We are looking at 90s. So with time, our cartilage will worn out. That is non-modifiable factor. But on the other hand, your modifiable factors, like if you don't do like high impact running, like if you just pound your joint again and again, like if you run marathon, like if you run 10 miles, like nearly every day, that means your joint is going to suffer comparing to other people. But if you, let's say, oh, I don't want arthritis, and if you just sleep and sit, the articular cartilage do not have a chance to do its job, because when we study about articular cartilage, it has got lots of water. This water need to come out into the joint, go back into the cartilage. So that is the way articular cartilage is functioning, and it is healthy. So yes, don't abuse your body. That's the only way. Some people are like footballers. Let's say footballers, they are really healthy people, but they don't live that long. Why is that? Because they injure their body pretty early in their life. So at the 45, 50s, might be early 55, they are looking at knee replacement already. So which means the chance of another operation is higher. The chance of operation related complications are higher, and they do not live long. So don't abuse your joint, but you have to support it with gentle exercise and good lifestyle, I would say.
Or like when someone has like a repetitive movement for their career, like a carpenter with the hammer, the carpal tunnel is different from arthritis?
Carpenters, they do get arthritis in the wrist.
Yeah.
And their shoulder, because they are moving quite a lot.
Yeah. Okay, that makes sense.
So just always think modifiable and non-modifiable factors.
Okay, thank you.
Arturo?
Yeah, my question was related to that too, but I was also wondering about the neck muscles. Our expressions are related to our muscles, right? Like there. That's why sometimes people, if they make too much expressions, they like the muscle. There's like muscle marks.
Yeah, muscle marks. Because the skin, like when we study about the skin, we saw the Langerhans line, like the skin lines. So it depends on the collagen in the skin as well. So let's say Caucasian skin, the white Northern European descendant Caucasian skin, they are really soft. They have a very soft skin. So when they are young, it's very soft and good. But when they get old, their skin is a little bit more, they wrinkle a lot more. So for those people, like South Asian subcontinent, like Indian. So their skin, I think they have better collagen. Therefore, they are not that flexible, but their skin lasts longer. So let's say Hispanic, Mexican, again, like their collagen is very good, I think. They don't wrinkle that easily unless they have a. So the skin wrinkles is related to their Langerhans line, and of course your external environment, like working in the sun, is not a good thing. And the more facial expression you do, of course, you got more wrinkle when you get old. Especially girls, they do a lot of facial expression. So I should stop. Okay, so the muscle on your forehead and the muscle on the back, it is the same. Hey, can you believe that? No, I cannot. Okay, if you don't believe that, I will show you here. So the muscle on your forehead is frontal belly. The muscle on your back is on the occipital bone. So occipital belly. But this muscle is called epicranius. Epi means outside, yeah? Cranius means cranium. So epicranius means around or outside the cranium. That's simple, isn't it? So it sounds a little bit funny, the muscle on the whole, forehead and the back, and even on the top vertex, it is the same. So what do we call that? It is around on top of the cranium. So epicranius. Of course, if it is on the frontal bone, it is frontal belly. If it is on the occipital bone, occipital belly. And they are attached, they are connected to each other with the epicrania. Aponeurosis. Aponeurosis. What is aponeurosis? Aponeurosis is the thick, flat sheet of collagenous connective tissue. So you are going to see a lot of aponeurosis in later lectures, like especially when we go to the abdomen, because abdominal muscles, they are enclosed within the multiple layers of aponeurosis. Aponeurosis is nothing more than a flat, thin sheet, very strong connective tissue. And epicranius muscle, epicranium, frontal belly, occipital belly, and epicranius aponeurosis. Easy. Temporalis muscle, easy. Look at this muscle. It is going circular around our eye. Hey, what is a good name for this? This muscle is going around the eye, which is in a circular. So around the eye, so oculi, it is going cycling orbit, like an orbit. So orbicularis oculi. Oh, you close your eye with orbicularis oculi, guys. Yeah. So I hope some of you guys are using your orbicularis oculi when you are doing the lecture. Closing your eyes.
Yes, we are.
Yeah, is that you, Amanda?
Yes, with my coffee. With my big cup of coffee.
Yeah, I have a big cup of coffee. But stay this orbicularis oculi is walking a lot. Huh?
We're wide awake.
Wide awake, okay. Thank you. So if we have orbicularis oculi around our eyes, we will have orbicularis oris around our mouth. It's that simple. It's human body is really funny. GS make you just support you with everything you want to do. So yes, orbicularis oris here, orbicularis oris. Hey, simple as that, around the mouth, going cycling as an orbit, orbital. So around the mouth, orbicularis oris. Around the eyes, orbicularis oculi. And then let's say if you clench your teeth, so just do it and put your fingers on the angle of the mandible. So put your fingers on the angle of the mandible and clench your teeth. You can feel the big muscle bulge out. That is what we call this masseter. And Lionel Messi, the footballer, masseter. It's the angle on the, it is on the angle of the jaw, the body of the mandible, the ramus of the mandible. This corner is called angle of the mandible. The masseter muscle is sitting on the angle of the mandible. Hey, you can feel it. Do it. Then you can clench your teeth. Then you can feel the big, thick muscle. It's like a temporalis muscle. You will feel the bulge of the masseter muscle. And just in front of our neck, underneath the skin, if we peel off the skin, we will see a flat sheet of muscle. This muscle is here. If you do that, you can see the flat sheet of big muscle in front, covering the front of the just underneath the skin. It is called platysma. Of course, the trapezius on the back of the muscle. Where is trapezius? Here, trapezius. So trapezius on the back here. You have seen trapezius multiple times already, because you have seen the trapezius space triangle, and at the lower part of the back, you will see latissimus dorsi, latissimus large dorsi at the back, big large muscle, latissimus dorsi, and this is in front of the neck, big sheet of muscle. That is what we call platysma. And trapezius. Hey, look at that, sternocleidomastoid. So it is coming from the mastoid process, or well, no, it is not coming from the mastoid process. According to the name, it is coming from the sternum, and the clavicle, and mastoid, going to the mastoid process, which is what you can feel just posterior to your ear. That's bony prominence, sternocleidomastoid muscle. Hey, these muscles are so easy. It's too easy for my student. It's too easy for my students. My students, epicranius, the whole cranium, epicranius, frontal belly, because it's on the frontal bone, occipital belly, because it's on the occipital bone. On the temporal bone, we have temporalis. Around the eye, orbicularis oculi. Around the mouth, orbicularis oris, and you can see the masseter, and you can see the sternocleidomastoid. You know that trapezius is too boring for you now, and you can see the platysma. So these little muscles here, don't worry too much about that. And where is the buccinator? Buccinator here. This buccinator is really important. You know, it is. You have to remove the masseter to see the buccinator properly. Here, buccinator, it's here. So this buccinator is really important because when we chew the food, so it keeps the food and push the cheek against the teeth. Otherwise, if the cheek bulge out, the food will not be sitting on our teeth, and we won't be able to chew. Therefore, this buccinator squeeze the cheek, pressing inside when we are chewing, so that the food can sit on the teeth. So this buccinator, masseter, orbicularis oris, orbicularis oculi, is so easy, so easy. Hey, epicranius, we have frontal belly, occipital belly. The nerve supply, which nerve is supplying this muscle? So it's facial nerve. Even at the back here, hey guys, our facial nerve is doing the job for us. So yeah, facial nerve, facial nerve. So now you know everything about these muscles. Don't worry about small little things in life. Don't worry about small little man who is giving you trouble. Just identify what is important and let's pick up what we need to know. Epicranius, temporalis, masseter, sternocleidomastoid. Forget about the trapezius. We know this muscle again and again already. Platysma, orbicularis oris, orbicularis oculi, bassinator. We know that bassinator. So yeah, right. This is the cadaver. Let's say if we have a chance to meet in the anatomy lab, and this is the cadaver you are going to see. I mean, what is a big deal? What is a big difference? No difference at all. The same thing, like the human body hasn't changed just because being drawn in the diagram and being in the cadaver or just a live patient you are operating on. A human body doesn't change. Epicranius, the same epicranius. I'm not going to repeat it. I'm tired. Everything is the same. Yeah. So, but you can now see the small little nerves running here and there, and you can see the zygomatic process coming from the temporal bone. Look at that. It's a beauty. It's a beauty. And let's move on. And as I say, don't worry about small little things in your life. Don't worry about small little thing in the textbook. Don't worry about small little man. You need to move on. Ha ha ha. Look at that. So now, hey, so this is the petrous temporal bone. So it is the ear, one of the ear canal. This is the zygomatic process. This is the zygomatic bone. The fracture, zygomatic fracture. What is this bone called? Maxillary bone, isn't it? Maxillary bone, we have maxillary sinus. Paranasal sinuses, maxillary sinus, they are just here. If they have inflammation, sinus inflammation, inflammation is itis, sinus inflammation, sinusitis, inflammation of the sinus. So maxillary bone is here. This is the zygomatic bone, and this is the zygomatic process coming out from the temporal bone. And this is the auditory portion, petrous portion of the temporal bone. And as I say, so we have our ear somewhere around here. As I say, this bony bump is the mastoid process where the sternocleidomastoid muscle attach. And on top of that sternocleidomastoid process, here is a very thin and tiny process coming out from the temporal bone. Here, this is what you can see partially here. That is what we call styloid process. Oh, it is like a styloid. It is just like, what shall I say? It is like a little needle coming out from the bone. It is so amazing, like very thin and small, like it might be about this pen size. We will call it styloid process. So now you know the styloid process, you know the mastoid process. The muscle attached to the mastoid process is sternocleidomastoid. And this, so the main aim of these processes in our body, what is the aim for these bony processes? Of course, they give attachment to muscles. So that is the importance of these bony processes, any bony processes in our body. So the mastoid process will give attachment to the sternocleidomastoid muscle. The styloid process coming from the petrous temporal bone, of course, it will give muscle attachment, and these muscles are, number one, look at that. Where is this? It's, if this muscle go to the tongue, coming from the styloid process, going to the tongue, styloglossus. Oh, it's so easy. if the muscle from the styloid process going to the hyoid bone here, hyoid bone, you saw the hyoid bone when we talk about the larynx, trachea, larynx. So hyoid bone, if the muscle is running from the styloid process to the hyoid bone, we'll say it stylohyoid, stylohyoid, from the styloid process to hyoid bone, stylohyoid. And if the muscle is going from the styloid process going to the pharynx, you know what pharynx is? Nasopharynx, oropharynx, laryngopharynx. If this muscle coming from the pharynx going to the styloid process, it is called stylopharynx, stylopharyngeus. Yes, so now you know these three muscles, and you can see the tongue here, big tongue sticking out, and you can see the genioglossus, big muscle here. So when we talk about we have to talk about the tongue at later lectures, but you know, muscles of the tongue, there are two types of muscles in our tongue, intrinsic and extrinsic muscles. Intrinsic muscle is, it is like, what do you call that? You cannot move the tongue, you can only change the shape of the tongue. So intrinsic muscles of the tongue, you roll your tongue, you point your tongue up to the hard palate, or you point your tongue back and up to the soft palate. You can do that. These movements, they are being done by the intrinsic muscles of the tongue. Well, sticking out the tongue, moving the tongue to the right, moving the tongue to the left. These are the muscles done by all the extrinsic muscles of the tongue. Look at that genioglossus. What is the direction here? So it will just pull the tongue down. Don't forget the thyroid cartilage, which you have seen. So yes, mestric process, styloid process, three muscles coming out from the styloid process. Do you really need to know these? Not really, but it's good to know. And you know, but if somebody says stylopharyngeus, it should come in your mouth, stylopharyngeus, from styloid process to pharynx. Stylohyoid, yeah, stylohyoid, I know this muscle. One is the air in the neck, from styloid process to hyoid bone. So that's the way, you know, you cannot remember everything in this formats, but at least you have some foundation to understand. And if somebody trick, then it clicks in your mind. So genioglossus, hyoglossus, styloglossus. Yeah, so these are the muscles. And genioglossus can depress or consult with the other extrinsic muscle, retract the tongue. Oh, easy. Now we just take a little bit more deeper, go a little bit deeper. And now we have removed the masseter muscle already. Now we can see the mestric process here, our O frame. Now we can see the styloid process here, little bony, sharp and pointing, very long, sharp and pointing. Styloid process here, mestric process here, the body of the mandible, angle of the mandible, temporomandibular joint will be somewhere here. You can see the bassinator muscle here. As I say, this bassinator muscle is keeping the food when you chew, like in position, so that when you eat, the food doesn't go away outside. It doesn't bulge out in your cheek. If we do not have bassinator, when we eat, we just like boom. When we eat, the upper teeth and lower teeth will not be able to grind the food in the middle. Okay, and you can see the hyoid bone here, and you can see the thyroid cartilage. Hey, this is the very prominent in boys, the most prominent point in front of our neck. And now we can start seeing the pharyngeal muscle. So as you know, the pharynx extends from back of the nose as a nasopharynx, back of the mouth, oropharynx, and back of the larynx, laryngopharynx, and finally it becomes larynx. Yeah. So we have three portions of the pharynx, and therefore we need to have three portions of the pharyngeal muscle. So they are uppermost superior pharyngeal constrictor, middle pharyngeal constrictor, and inferior pharyngeal constrictor. That's it. Yeah, that's it. So it is not difficult at all. So pharynx, three portion, nasopharynx, oropharynx, laryngopharynx. So we have three pharyngeal muscle, superior pharyngeal muscle, middle pharyngeal muscle, and inferior pharyngeal muscle. Well done. So just take the platysma off. And now you can see the sternocleidomastoid muscle. As you know, you can see that, hey, this is the manubrium sternum. This is the clavicle. Coming from the sternum, coming from the clavicle, going to the mastoid process, sternocleidomastoid muscle. This is a really big, thick, and very important landmark when you do operation around the neck. So you need to know that sternocleidomastoid, because you might be somebody who is operating on someone's neck. So at least at this stage, you need to know the sternocleidomastoid muscle. And from the front, we can see the hyoid bone, which is the top bone, hyoid, and thyroid. Hey, this is the thyroid, which is what we call Adam's apple, the prominent thyroid cartilage. And at the bottom, we have the hyoid, cricoid cartilage. Yeah, cricoid cartilage. And this is where our thyroid gland, which is just here. And small little things, because it is easy to say, you don't need to remember these. Myohyoid here, mandible to the hyoid bone, myohyoid. Stylohyoid, look at the coming from the styloid process to the hyoid bone. This is the hyoid bone. Sternothyroid, coming from the sternum. Where is the sternum? Hey, here sternum to the hyoid bone, sternocleidomastoid. Thyrohyoid, means coming from the hyoid to thyroid, thyrohyoid. You don't need to remember this, but at least if something is if these names turn up, you know at least where they are. So I don't want you to say, hey, sternocleidomastoid. Hey, sternocleidomastoid is in the buttock. No, sternocleidomastoid is not in the buttock, not a buttock muscle. Sternocleidomastoid is coming from the sternum to going to the hyoid bone. So at least, just trying to make sense so that, but with time and time again, if we go back, we will gradually know more and more. These are the origin and insertion. Let's forget about that. Okay, let's keep moving. Sternothyroid, omohyoid, then just have a little look, nothing, no pressure at all. Just for completeness here. Now we talk about the orbicularis oculi, okay, closing the eye around the orbit like around the eye, orbicularis oculi, orbicularis oris, platysma. And I want you to have a look at this diagram for about this page for about 30 seconds. I'm going to give you 30 seconds. And I want you to have a look. Something really salient, significant. The whole from here to here. From here to here. I want you to have a look because it is so obvious. It's so obvious. Okay, 30 seconds. Now I'm going to show you another slide. And I will take another 30 seconds. Okay, 30 seconds is too long. I'm going to move on. I will give you 10 seconds. Because it is so lovely. If you see that, you will say, ah, Professor. Okay, now 10 seconds, the whole from here to here. So just scanning, yeah? Scanning the slide here, from here to there. Okay, I'm going back again, scanning from here to there. From here to there. And here to there. What do you see? No one talk to me. Right. So what I was going to show, if you do not answer, I will answer that. So what I want to see is, look at these muscles here. The nerve supply for these muscles are facial nerve, 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 and facial nerve, and facial nerve. What does it mean? So the whole, every muscles on our face, or nearly every muscle on our face, is supplied by the facial nerve. So like if a girl is making a lot of movement on their face and a lot of whatever she does, she is just using her facial nerve. Yeah. So orbicularis oculi, facial nerve. Orbicularis oris, facial nerve. We didn't talk about this muscle. Zygomaticus, facial nerve. Platysma, facial nerve. Fascinator, facial nerve. Oh my God. Fascinator, depressor anguli oris, facial nerve. So what it means is, the muscles for the facial expression, like you smile, you cry, you laugh, you tense your face, everything, your facial muscle movement, you need help with the facial nerve. Facial nerve is the seventh cranial nerve. There are 12 pair, like right and left, 12 pair of cranial nerves, 1 to 12, and facial nerve is 7th cranial nerve. And this facial nerve is moving your face upside down, yes? And the only important thing is the important muscle, masseter muscle and temporalis muscle, they are from the trigeminal nerve. Trigeminal nerve is 5th cranial nerve. So yes, masseter, trigeminal, temporalis, trigeminal. But this is motor. So motor facial nerve is the main motor supply, motor movement supply of the facial expression. So don't underestimate your facial nerve, and it is giving you the whole facial expression for you. Okay, so now look at that platysma. Hey, that's your neck, and that is the big, flat, thin muscle covering the whole front like an apron in the neck. That is the platysma. Yeah. So of course, if we bang, where is the platysma? Removed already, and you have seen this muscle already. You can see this muscle coming from the sternum, coming from the clavicle, combined together, going to the mastoid process, sternocleidomastoid muscle. Hey, look at this muscle. It looks like coming from the sternum, going to the hyoid bone. This is the hyoid bone. So this is sternohyoid. This is the thyroid cartilage, which is adheres above. Omohyoid, superior belly, inferior belly, sternothyroid coming from the sternum, going to the thyroid. Sternohyoid, hyoid bone. stylohyoid. Oh, it's simple. You don't need to remember that this is a difficult stuff, but at least you have a little basic idea about muscles in the neck. When we go back again, these will become more and more easier. Look at that. There you can see the thyroid cartilage. Hyoid bone is here above the thyroid, hyoid, and cricoid. Cricoid cartilage is here. So this is this person is a very good model of showing these bones, hyoid, thyroid, and cricoid. So when we do tracheostomy usually goes in between the thyroid, laryngeal cartilage, and cricoid cartilage. So you have to go in between here. That is the tracheostomy. You can see the sternocleidomastoid muscle here. You can see the sternocleidomastoid nice and sharp. You can see the clavicle here. And subclavian artery is very close to underneath the clavicle here. Look at the sternocleidomastoid from the mastoid process coming to the clavicle and going some portion going to the sternum. And you can see the notch in the upper manubrium sternum. That is what we call jugular notch. Sternocleidomastoid, sternal, and clavicle end. Right, external jugular vein is somewhere around here. Look at that. And external carotid artery position point is here. You have to feel it here. Right, so, okay, I'm going to stop for like about 5 minutes because it's an easy morning. So we just stop about 5 minutes. We meet at 11:05 and we just carry on. The rest is not much to absorb more, but let's take it simple. Just take about 5 minutes break, go and have water, go and have fresh air and come back. Yep. And now, look at that, just for orientation, this is the right side, this is the left shoulder, and this is the left ear. The person is moving up and trying to show the sternocleidomastoid. What do you have to do? You have to push against your chin and the mandible, push against the resistance. And therefore the sternocleidomastoid will become prominent. And this is the chin, and this is the midline. So midline of the neck, and you start seeing the sternocleidomastoid muscle. You know the sternocleidomastoid muscle coming from the sternum, coming from the clavicle, combine together, and then go to the mastoid process. That's the sternocleidomastoid muscle. Just in the middle, if you in the midline, come and attach to the manubrium sternum, you feel the little notch. That is what we call jugular notch. So this is a pretty simple photo, which we see ourselves in the mirror every day. But let's try to have a little bit more educated eye. So let's try to have a little bit more educated eye. What is this? What is this? Of course, on this side, on this line is along the midline of the neck. And this is the jaw, mandible, lower border of the mandible. And here, this is the anterior border This line is drawn along the anterior border of the sternocleidomastoid muscle. Now you have a little triangle, guys. Hey, what are you looking at? I can see you even if you close your camera. So yeah, so this is the triangle we get midline along the anterior border of the sternocleidomastoid and along the inferior border of the mandible. And let's give it a name because it is in front of the neck. We'll say anterior triangle of the neck. So that is not difficult at all, isn't it? Anterior triangle of the neck. If we have anterior triangle of the neck, we will have posterior triangle of the neck. So let's try to solve the problem here, this anterior triangle of the neck. Anterior triangle of the neck, boundaries. Anterior boundary is in the midline. Posterior boundary is the anterior margin of the sternocleidomastoid muscle. Superior is the lower border of the mandible. And so its apex is at the jugular notch. Wow, simple as that. Anterior triangle of the neck, midline, anterior border of the sternocleidomastoid, which is sternocleidomastoid is here, and lower border of the mandible. And its apex of the triangle is pointing to the jugular notch. Simple. Why does it important? So if you want to do any surgical procedure, if you want to manipulate somebody's skin or neck in this anterior triangle of the neck, you need to have some knowledge about this neck. But why is it important? Hey, our carotid artery is just there. Big pumping artery coming out just after coming out from the aorta. Pumping carotid is just in the anterior triangle. Internal jugular vein, which is going to become superior vena cava. It is in the anterior triangle. So hey, don't mess around in anterior triangle. Be careful, be gentle. And submandibular gland, this is the salivary gland. It's underneath the mandible, submandibular. Of course, we include this boundary in the lower border of the mandible. So the submandibular gland is in the anterior triangle. And infra and suprahyoid muscle, that's not important. That's small little things, forget about that. So carotid artery, internal jugular vein, and submandibular gland, they are in the anterior triangle of the neck. Look at that. So now the body has turned slightly in a different way. We can still see the sternocleidomastoid. This is from the mastoid process. This is the angle of the jaw, This is the midline, sternocleidomastoid coming to the clavicular head and going to the sternum, manubrium sternum, so sternum head. And you remember this trapezius at the back of the body, And now if we have that clear, look at that posterior border of the sternocleidomastoid. This is the middle third of the clavicle. So clavicle from here to there, clavicle from here to there, medial third, middle third, and lateral one third. So this is the middle third of the clavicle. And here, trapezius muscle, if you draw a line along the anterior border of the trapezius, that is the boundary. Now we have another triangle. This time, this triangle is pointing upwards. Yeah, so pointing upwards. The simple sternocleidomastoid is dividing our neck on each side, on right side and on left side, dividing the neck, right side of the neck into anterior triangle and posterior triangle. And this is the posterior triangle. So now you see the posterior triangle of the neck. It is also important because of the contents in this posterior triangle of the neck. So boundaries, anteriorly, posterior margin of the sternocleidomastoid, posteriorly, anterior margin of the trapezius, inferior middle third of the clavicle, apex is at the sternocleidomastoid and trapezius. That is what you see. It is so simple. But you need to remember this diagram, which makes things a lot easier. Hey, now this is the sternocleidomastoid. You can see the posterior border, a line drawn along the posterior border. You can see a line drawn along the anterior border. This is the trapezius. You can draw a line from the anterior border of the trapezius. This is the clavicle. This is the posterior triangle of the neck. So this sternocleidomastoid is dividing on the right side and left side into two triangles. So now you can see posterior triangle of the neck. This is the trapezius, anterior border of the trapezius, posterior border of the sternocleidomastoid, and middle part of the clavicle. This is the posterior triangle. Anterior triangle is one is in the midline, another is in the anterior border of the sternocleidomastoid, and the number 3 is inferior border of the mandible. This is the angle of the mandible. This is what you call ramus of the mandible, and this is another green triangle. So anterior triangle of the neck, posterior triangle of the neck. Contents of the posterior triangle of the neck, it is really important because we have the 11th cranial nerve. We said there are 12 on right and 12 on left. So 12 pairs of cranial nerve, 1 to 12. 7 is facial nerve, 5 is trigeminal nerve, and this 11th cranial nerve, which is called spinal accessory nerve, is in the posterior triangle of the neck. Therefore, you know, when somebody takes lymph node biopsy in the posterior triangle of the neck, they can damage the 11th cranial nerve. So be careful. And nerves, so cervical plexus, so the nerve, mesh and meshy nerve for the neck, mesh and meshy break here, so for the arm, the phrenic nerve, cervical 3, 4, 5, keep the diaphragm alive, which move the diaphragm when we talk about the respiration. So all these nerves, they are all in the posterior triangle. So be careful when you are operating on the posterior triangle of the neck. Blood vessels, subclavian artery, and external jugular vein. And of course, lymph nodes, occipital nodes, supraclavicular nodes, they are in the posterior triangle. So when we are going to fish occipital node or supraclavicular node, lymph node biopsy, we are going to damage these structures. So be very cautious if you have to operate on the posterior triangle of the neck, because you can easily feed the lymph node, you know, enlarged lymph node, supraclavicular lymph node in the posterior, in the posterior triangle of the neck. It is very tempting to jump in and just do the operation, but be careful. You can damage the 11th cranial nerve. You can damage the cervical plexus, phrenic nerve. It is a little bit deep, or brachial plexus. So they are just there waiting. So look at that. This is the posterior triangle of the neck. This is the anterior triangle of the neck. Hey, this is the internal jugular vein, which we can feel here. The carotid artery, hey, we can feel that here. So if you want to feel the carotid artery pulsation, you have to go to the anterior border of the sternocleidomastoid. Yeah. So anterior border of the sternocleidomastoid. So because the carotid arteries, they are in the anterior triangle. And the posterior triangle of the neck, here subclavian artery and external jugular vein here. Right, so that's pretty easy, isn't it? If you are aware, things become easy. So if you want to operate on somebody's neck in the posterior triangle, you will be cautious, you will take step by step, and you know what you can damage, you look for it. So if your mind knows, your eyes see, your hands can feel as well. So that's the good thing. Yeah, you know, the problem is the mind doesn't know. Then because the mind doesn't know, the eye cannot see, even if it is in front of you, and your hands cannot feel. That's where the problem starts. So you need to feed your mind. You need to feed your mind. So now look at the chest. Oh, come again, sternocleidomastoid. I'm a bit fed up because it is coming from the middle part of the clavicle. It's coming from the sternum, manubrium sternum, go up to the mastoid process, sternocleidomastoid. This muscle keep coming again and again, again and again. Therefore, it is important. And this is on our chest. So for the girls, remove the breast. For the boys, remove the breast. If we remove the breast, then we have the big muscle here on the chest. That is what we call pectoralis major. Pectoralis major. Big muscle, pectoralis major. If we remove the pectoralis major, we will see the pectoralis minor. Look at that. 3, 4, 5 ribs going to the coracoid process of the scapula. Well, is it important? Yeah, it is important. Why? Because if we are doing the deep effort respiration, like if someone is having asthmatic attack and if they are struggling for breath, they are using the accessory respiratory muscles. This is the muscle, pectoralis minor. And of course, sternocleidomastoid muscle as well involve sternocleidomastoid, pectoralis major, and scaling muscle. We cannot see scaling muscle. If we want to see the scaling muscle, we have to remove the sternocleidomastoid muscle. So scaling muscle, sternocleidomastoid muscle, and pectoralis minor, they are important for labored breathing, accessory inspiratory muscles. So now you make sense now, everything comes together. And big on the chest wall, we have the big pectoralis muscle. If we remove the big pectoralis muscle, we will see the pectoralis minor muscle. And now this big muscle on our shoulder is called deltoid muscle. That is the muscle which make the shoulder contour. Yeah, shoulder contour. So the big deltoid muscle here, pectoralis major. So for those, I have seen a few photos of some students. I think they do some gym exercises. So they got big deltoid with big arm muscles. So deltoid, it is a big deltoid muscle here on our shoulder, which makes the contour. This muscle is at the back, trapezius muscle. And pectoralis major muscle, and this pectoralis minor muscle coming from the 3, 4, 5 ribs and going to the coracoid process of the scapula. Hey, the coracoid process, as we say, bony prominence, bony processes, they are important because they give muscle attachment. Now it comes again, this coracoid process of the scapula is giving muscle attachment to the pectoralis minor, and it is giving another muscle attachment from the coracoid process going to the diaphysis of the humerus. So mid-humerus diaphysis, that muscle coming from the coracoid going to the humerus. What is the name? What is a good name for that? From the coracoid process to the humerus, coracohumerus muscle. No, not coracohumerus, coracobrachialis. Brachialis means arm, brachii, arm, coracobrachialis means from the coracoid process to the humerus, brachii, M. So coracobrachialis. It's so easy, guys. Coracobrachialis going to the mid diaphysis. And if you do not go deep, if you just keep superficial, deltoid, you can see the pectoralis major and you can see your biceps muscle here. So you cannot see the coracobrachialis muscle, but you can see the bicep brachii muscle. Bicep brachii means arm, bicep means 2 heads. Bicep brachii, 2 heads in the arm. So this is what we see now, pectoralis major, pectoralis minor. Pectoralis minor, we go and attach to the coracoid process. In the coracoid process, the coracobrachialis muscle arise. Hey, look at this coracobrachialis. It is the most medial. deltoid muscle here. We cannot see the bicep here yet. In between the deltoid, big, thick, fat deltoid and big, thick, fat pectoralis major. So one big muscle here finished, one pectoralis major finished. There we create a little groove. In that deltopectoral groove, we have a big vein, big juicy vein, which is called cephalic vein. Cephalic means on the head end. So cephalic vein is here. So if we want to operate on somebody's shoulder, we will take advantage of this groove. Deltoid muscle, pectoralis, pectoral, deltopectoral groove. So we don't need to get any muscle. We just split, push the deltoid on the deltoid side, push the pectoralis major on the pectoral side. So we create a little plane, which is bloodless, no bleeding at all. So we, of course, as long as you don't damage the cephalic vein. So deltopectoral approach going into the shoulder. It is a really important approach for the surgeons to go and operate on the shoulder. But be careful with the cephalic vein. So let's go the upside, the pectoralis major, remove it. We can see the pectoralis minor. Pectoralis minor came from 3, 4, 5 ribs. Go and attach to the coracoid process. And from coracoid process, the coracobrachialis muscle is here. Hey, now be careful. On the lateral side of the coracobrachialis, here, we have the bicep muscle. Oh, be careful. Bicep, brachii, biceps, 2 heads. Yeah. So one head, look at that. If you trace the bicep here, one head is coming from the glenoid. You remember the glenoid? For the glenohumeral joint, shoulder joint. The upper portion of the glenoid, superior lip of the glenoid, it gives attachment to the long head of bicep. And this another head, biceps, so 2 heads. One set is going to the glenoid. Another one is following to the coracoid process. So biceps 2 head, one coming from the coracoid process and another coming from the glenoid superior labrum, and which makes the big bicep muscle here. Of course, this bicep component is also together with the coracobrachialis. So this is a really important, guys. The coracobrachialis is more medial, and biceps, if you want to know whether it is bicep muscle or coracobrachialis muscle, you need to check the arrangement. One is more medial and one is more lateral. And if you are not sure, you have to trace the head. Biceps has 2 heads, one going to the coracoid process, and there must be another head going to the glenoid labrum. Oh my God. Serratus anterior is around here. Remember, serratus anterior, it is coming to the thoracic wall. We will go into detail later. Hey, flip around, look from the back. You can see the deltoid here. The big muscle we were talking about, latissimus dorsi, latissimus dorsi, latissimus dorsi. Latissimus, large dorsi in the back, large back muscle. Latissimus dorsi, and triangular muscle, the trapezius muscle, triangular muscle. So if we remove the trapezius and the deltoid, we will see the deeper muscle. So deltoid and trapezius are superficial to these muscle, which is attached to the posterior surface of the scapula. You remember the scapula, spine of the scapula. Divide the scapula, posterior aspect of the scapula into supraspinous fossa and infraspinous fossa. In the supraspinous fossa, we have the supraspinatus muscle. In the inferior part of the spine, infraspinous fossa, we have the infraspinatus muscle. So supraspinatus, infraspinatus. Sit tight, guys. This is nearly done, nearly done. Supraspinatus and infraspinatus, together with teres minor and teres major. Oh my God, something is big is going to come up. Supraspinatus, infraspinatus, and teres minor together with the subscapularis. So this is the anterior view, subscapularis, supraspinatus, infraspinatus, teres minor, not teres major, teres minor, and subscapularis. It is the muscle on the anterior surface of the body of the scapula. So all four muscles, the group of these four muscles are called rotator cuff muscles, R-O-T-A-T-O-R, rotator, C-U-F-F, cuff, rotator cuff muscle. Hey, which move your shoulder. So these muscles are really important, you know. When we get to 45, 50, 55, 60, then you have been using these muscles for 50, 60 years now. These muscles will get irritated. So that is one of the big issue, like these rotator cuff muscle gradually worn out. So that is the exam question: supraspinatus, infraspinatus, teres minor, and subscapularis. These four muscles walk together as a rotator cuff muscle. So deltoid is not included in the rotator cuff. So now you can see the coracobrachialis. You can see from the coracoid process of the scapula. This is anterior view. This is the right anterior view. We have removed the thoracic cage already, and we can see the anterior aspect of the scapula. You can see the subscapularis muscle, and this is the coracobrachialis coming from the coracoid process to the brachii, humerus, coracobrachialis. And I said it stopped at the mid-diaphysis. And from the mid-diaphysis, another muscle will arise again. So this muscle from here to there can, and this muscle from here to there start and go. That muscle is called brachialis, coracobrachialis and brachialis. There is a difference. Coracobrachialis is came from the coracoid, brachialis is in the arm muscle. So now you can see the supraspinatus in the supraspinous fossa, infraspinous fossa, and the teres minor, teres major. Minor is on the upper, major is down here. And don't forget the rhomboid muscles here, rhomboid muscle on the medial aspect of the scapula. Latissimus dorsi, trapezius. So yes, origin and insertion, have a look. I believe to some extent, you know, you guys have vague idea about where it comes and where it goes. Trapezius, levator scapulae, rhomboids. Hey, look at that. This is the pectoralis major. This is the deltoid. That's a little groove, which we call deltopectoral groove, where the cephalic vein is lying there. If we are careful with the cephalic vein, we can split these two muscles without any major bleeding, and we can get into the shoulder joint. And this approach to the shoulder joint is called deltopectoral approach, deltoid and pectoral deltopectoral approach. Bicep brachii, you can see that on the medial side, you can see the very part of the coracobrachialis, which is mainly covered with the biceps, and brachialis is also covered with the biceps. We have to remove the biceps to see the coracobrachialis and brachialis muscle. So this is the posterior view of the right shoulder, spine of the scapula, supraspinous fossa, supraspinatus muscle, infraspinous fossa, infraspinatus muscle. This underneath is teres minor and teres major, supraspinatus, infraspinatus, teres minor, and subscapularis makes the rotator cuff muscle. On the posterior aspect of our arm, in front we have bicep, at the back we have tricep. Tri means three heads. Oh my wow, triceps, 3 heads. You can see the tricep muscle on the posterior aspect of the arm. The same picture showing you again and again. It's the subscapularis. This is the anterior view. The whole chest wall has been taken away. We can see the anterior aspect of the scapula. And this is where the subscapularis muscle is. We can see the clavicle, acromioclavicular joint, coracoid process. Long head of bicep, one is coming from the coracoid short head, another one coming from the glenoid long head. This is originate insertion. I want you to have a little look, but don't worry too much about memorizing completely, because it's easy to remember in a simple and understanding way. Oh, so that is, I hope it is not a lot, but I think it is interesting. So for the whole morning, we have been talking about